Hi, Brandy.
Hi, how are you?
Can you hear me?
Yeah, I can hear you.
Well, I couldn't make it to the office. I'll have to do it from home.
It's fine.
I don't know how you made it, but it's crazy out there. So I just wanted to check beforehand if my presentation can be loaded. So I'm going to share my screen. And can you see it?
Yes.
Is that right?
Yep, that's perfect.
Okay. So in order for nothing to happen, well, why don't we just keep it at this
Yeah,
slide?
yeah,
Okay.
you can leave it like that. It's
Okay.
fine.
How are the roads this morning?
I didn't think they were too bad until I got to Morgantown.
Is that right?
Yeah.
Yeah, you would think it would be the opposite, that the town would be better than outside.
Yeah.
Where do you drive from?
I drive from Clarksburg. I'm about an hour away.
Oh, okay. So even more south.
Yes.
Okay, good. Well, you're certainly a brave girl. I couldn't put myself this. It was between me giving a grand rounds from home or from a ditch. So I choose
Yeah.
the former.
Yeah, I typically make it.
Good morning, everyone. Welcome to this week's Medicine Grand Rounds. Just a few reminders for those joining remotely. Please make sure that your mics are muted to avoid any unintended interruptions for our speaker today. Please ensure your full name is on your Zoom login so you can be easily identified. And if you are logged in as a group, please email Department of Medicine Grand Rounds at hsc.wvu to receive credit for today's lecture. If you have not participated and received credit for Grand Rounds via Zoom before, please complete the credit request form located in the chat box during the Zoom lecture. This ensures we have the appropriate information on file. We will save time for Q&A at the end, and if you type your question in the chat, I will work to relay those questions to our speaker. We will try to wrap up around 8:55 in order to get back to our clinical duties. With that, we are thankful to have Dr. Sunil Sharma. Dr. Sharma completed an internal medicine residency in Chicago, Illinois in 1998 and went on to complete his pulmonary disease and critical care medicine fellowships at University of Wisconsin Hospital and Medical College of Wisconsin, respectively. He additionally completed sleep medicine training while in Wisconsin. He subsequently has had a multitude of academic and administrative appointments at institutions such as University of South Carolina, Thomas Jefferson University, and Einstein Medical Center. In 2019, he joined us here at WVU, where he currently serves as the section chief of the Division of Pulmonary Critical Care and Sleep Medicine, and is additionally the director of Sleep and Respiratory Medicine Program Development here. He is extensively involved in research and resident and fellow education, and has given numerous division, regional, and national and international presentations. We are thankful to have him here today to discuss disruptive innovation to address the sleep health crisis. Please join me in welcoming Dr. Sharma.
Thank you so much for your kind introduction. Can everybody hear me? So I see the silver lining of the Zoom Grand Round, finally. So the choice this morning was to take a Grand Round from home or from the ditch. So I chose the former, so I'm so glad about it. I have no conflict of interest to disclose. Other than being a member of the American Academy of Sleep Medicine Inpatient Task Force. So let's start with the topic of today, disruptive innovation to address sleep health crisis. And, different people have different ideas of what disruptive innovation is. So I wanted to clarify that according to business theory, disruptive innovation is any innovation which has the potential of making the current model or current innovation obsolete or near obsolete. So with that in mind, I'll try to create a scenario of how sleep industry has moved, the medicine and science, and how it's evolving. So why are we talking about disruptive technology and disruptive innovation when we mostly have been familiar with what we call as the incremental innovation? Example being, we had chest x-ray, and we advanced to CAT scan. Well, chest x-ray remained there. We advanced to MRI. So we are used to that. We are comfortable with that. So what's the idea of disruptive innovation? Well, these two slides will tell you why exactly it's needed. The first slide over here shows you that a GDP, or the US healthcare expenditure, was almost 5% in 1960s, has gone up to 18% of GDP that we spend, and with not really much good outcome, even compared to many other countries in the Western Hemisphere. We are one of the lowest performing. So it was time that this model isn't working and some course correction is required. Some of you may be surprised, maybe even shocked, that the most recent literature, including Adam Benjafield's work from Australia, looking at the prevalence of sleep disorder in the world, puts at 1 billion people suffering from sleep apnea. Compare this with diabetes of 463 million, hypertension 972 million, and even COVID, which we heard at Grand Rounds from Dr. Savari a week or two ago, of 328 million. So this is truly a silent pandemic, which we have failed to recognize. Even in the United States and the Americas, we stand at 170 million people suffering from sleep disorder, potentially. Now, this has come in at a staggering economic cost to the society. So between workplace accidents, motor vehicle accidents, lost productivity, and comorbid diseases, we lose about $150 billion, billion with a B, on a yearly basis just because of this disease. But we are very good at diagnosing. So we have a gold standard polysomnography, and we can with very high accuracy tell you whether this disease is present and how to treat it. So our knee-jerk response was, yes, we know things are getting bad. What are we going to do? Well, we're going to create a sleep center. Well, what if the demand outstrips the supply? Well, we're going to have more sleep studies. And if we run out of land, we're going to open sleep labs in a hotel. And that's what we did. And we continued to chase this mirage. And somewhere we lost the narrative because our only reaction to this growing pandemic was creating more and more sleep labs. And of course, you all know there were months and months of delays of wait for sleep labs, even further wait for CPAP titration studies. And sometimes by the time patient really got the treatment, it could be 6 months to 8 months down the road. So certainly the system wasn't working. So put in a little historical perspective. 2007, David Nielsen, who was the CEO of the American Academy of Otolaryngologists, went to the CMS and said, look, this isn't working. There's a lot of evidence out there that home sleep studies can do an equally better job, and then cut off all these lines and everything and help us out. There was a pretty significant, strong reaction from sleep societies, and I'm going to quote some of these to you. During the deliberation process, the CMS heard objections, some of them from medical professional and organization, including the American Academy of Sleep Medicine, unconvinced that the change was called for, and if this is in the best interest of the patients. Another high-level expert said a home study doesn't take the place of a laboratory study, and he continued, spending a night in a sleep lab has enormous benefits for relatively little cost, but the sleep community has not voiced that view. It just rolled over and played dead. It's terrible. So there was a significant backlash, but I think by the time we had lost the narrative. 2008, Medicare approved coverage for home sleep study. And this came with devastating consequences, because in 2013, Sleep Health Center, which is the largest chain of sleep health labs affiliated to Harvard, declared bankruptcy and closed doors. This was followed by hundreds of sleep labs across the landscape of the United States. And this, by the way, was our first taste of disruptive technology in sleep medicine. So we really feel that we missed the boat on this one, and we could have done a better job recognizing, having a narrative, and going from there. While this drama was being played, we in Jefferson at our lab were struggling with another question. We knew that this problem is huge, but we also understood that most of this problem is like an iceberg. What you're seeing is a very little amount which is above the water, and most of this disease is unrecognized, sometimes even without any symptoms. And this was corroborated by a great data by Javaheri published in the Blue Journal, which looked at heart failure patients and found that 70% prevalence of sleep disorder in that population, with only 2% of these patients being diagnosed. So we said, okay, whatever is above the water can be taken care of by PSGs and HSTs. But what about the 90% of the disease, which is unrecognized and sometimes even asymptomatic? We were also cognizant that data has been collecting for decades that sleep disorder breathing has strong association with arrhythmias, sudden death, hypertension, heart failure, COPD, MI, stroke, and fatal pulmonary hypertension. And where do you find all of these bad actors? These bad actors are found mostly in high proportion in hospitalized patients. And yet, almost 100% of sleep practice was in suburban areas. And we found this to be a major disconnect. Our preliminary data actually showed that this may be true, but at that point, nobody was listening. Until the founding editor-in-chief of JCSM at that time, Stuart Kwan, looked at our preliminary data and invited us to write about our thoughts. And this is the first time hospital sleep medicine came into the public consciousness. And we described what we felt, why hospital sleep medicine was needed. But just having a theory, just having a thought process that this is contributing to this pandemic wasn't enough. We had to do more than that. So in a very simplistic term, we use sleep disorder breathing as an umbrella term for OSA and CSA. In very simplistic terms also, obstructive sleep apnea is any time you have closure of your throat, collapse of your throat when you're sleeping, while central sleep apnea is when you forget to breathe. For whatever reason, we categorize both of them, although their pathophysiology is very, very different, as mild, moderate, and severe within the same scale of 5 to 15 being mild, 15 to 30 being moderate, and more than 30 being severe. This categorization is very important. The reason being that there is very little literature that any sleep disorder breathing, which is mild, we're talking about 5 to 15 times a minute, has any cardiovascular comorbidities. So we're really looking at a bandwidth of 15 above of sleep disorder breathing with significant cardiovascular implications. So our first task was, yes, we have theorized that this is a big problem. This may be the 90% of the hidden problem, but we had to go in and show that this is really true in terms of prevalence. We also had to show that this could be done in a cost-effective way, because that's one of the fundamental principles of disruptive technology. And then, of course, have an intervention which is effective, which, of course, as non-invasive ventilation, it turns out is pretty effective for sleep disorder breathing. And then, of course, after all of this, we had to show that if we put in all this efforts and logistical support, does it make any difference? So the first thing we realized very quickly in our lab was that sleep questionnaires will not cut it. And the reason for that is that it does have a good sensitivity of 74, 93, and we have feasible sleep questionnaires like STOP and STOP Bang, which are very easy to administer. The problem it has got is it's got very low specificity, which basically means that we're going to have a significant amount of false positive cases all over the hospital. And that would create a logistical nightmare and would be very difficult to deal with. So although some studies had already shown that there is significant high prevalence even with the sleep questionnaire, we weren't convinced that this is the right way to go. So what could we do? So we were very familiar as pulmonologists with pulse oximetry. Most of you also are. The principles are very simple. You use red and infrared light, which is emitted from a diode and then accepted on the other side of the finger with a receptor diode. And these infrared and red rays are then differentially absorbed by the blood, which gives you the saturation. Now, for many, many decades, the utilization of pulse ox now and even then was for chronic oxygen deprivation. Sustained oxygen deprivation, which we knew would hurt the body, is what we were chasing: COPD, interstitial lung disease, pneumonias, things like that. The problem with pulse ox, the original versions, were that the number of signals produced were huge, tremendous amount. To give you an example, there's 600 signals emitted per second by this diode. It's not possible for human brain to comprehend that. So the engineers came up with a solution is that we're going to just average. Since you're looking for chronic oxygen desaturation and sustained, it shouldn't make a difference. So they clubbed all of these signals to 20 seconds and caught in an average of 20 seconds of pulse ox, and it served us pretty well. Now, the problem is, if you look at the area which I've highlighted, this is your sustained oxygen desaturation, does its job. But when sleep apnea came in, we were not looking at the same disease. We were not looking at a sustained oxygen drop. We were looking at a very intermittent drop in oxygen throughout the night. For that, we had to go and make it more high resolution. So at least have an averaging time of less than 10 seconds. So we went by and took some of these pulse oximeters and said, let's see what happens. And we biocalibrated them to an averaging time of 3 seconds. And you can see the rest of the graph. Lo and behold, we started noticing these intermittent oxygen drops, which are going all the way till 70. And we felt that this technology can really help us. It's of course cheap, it's readily available, and can be very, very effective in screening these patients. But apart from theory, our screening model was a two-tier screening model. Now let's take advantage of the high sensitivity of the STOP questionnaire. Once we have them, then we're going to subject them to the screening test by high resolution pulse oximetry by biocalibrating it, and reduce and increase the specificity. So all of this was good and looked good on paper, but we had no proof that this works. So then came this one of the largest trial, looking at 754 consecutive patients at Einstein and at Jefferson, I'm sorry, where we looked at these patients who underwent this model and had a gold standard polysomnography within 48 hours of discharge of the patients. And lo and behold, what we found was that it worked. So not only we proved that there was significant in-hospital under-recognition of this disorder, but we also proved that we were right 87% of the time compared to the gold standard PSG. What surprised us during this whole exercise was looking at these yellow bars. The majority of them turned out to be moderate to severe. And if I told you a few minutes ago that this is the segment which has the maximum cardiovascular implications that we know of. So a large population of these patients in the hospital were turning out to have moderate to severe disease. So we did many studies, and in the interest of time, I'll not go to that. But the other question was, can we then apply these principles to rural health disparities? You know, cost is an issue. We have a clientele which has limited access to healthcare. Many times, you probably know as much as I do that sometimes hospital is the first contact for these patients with healthcare. So we have an extra responsibility towards rural health disparities. So we said, how can we check this thing is working over here? So this is the largest study which we've done here in West Virginia University, using CMS approved home sleep study and comparing our high resolution pulse ox on hundreds of patients in WVU. We came to the same conclusion that there's a significant overlap and between high resolution pulse ox and CMS approved home sleep studies. And these were done on the same patient the same night. So we were convinced that this works, and this is just hot off the press, published this month. We also are aware that COPD is a major issue, not only nationally, but in our state. We actually infamously have the highest prevalence of COPD in US. But what is most disconcerting about COPD here in West Virginia is that we have the highest rate of readmissions and hospital admissions compared to the entire country. And also more people dying of COPD as compared to the rest of the country. Now, you already are aware of the literature. We've done a lot of work in COPD admissions. Do they are not compliant with their treatment when they go home, they start smoking and so forth. And a lot of plans have come to the place. What we had never looked at was what happens if you have two diseases combined together, which is sleep apnea and COPD. So this is our first attempt at looking at that. And we were surprised that patients who were admitted to the hospital with COPD exacerbation had 50% prevalence of sleep disorder breathing, which means that every 1 in 2 patients you admitted for COPD exacerbation in a hospitalized situation has underlying COPD, which you're missing. Now, we looked at what happens to the outcome. The outcome was readmission or death, just like the problems we are facing. And we were surprised to find that the patients who have this combined disease, or the overlap syndrome, as we call it, has twice the likelihood of dying of readmitting as compared to the COPD who don't have sleep disorder. Even worse, there was a dose-response relationship. So the more severe the OSA of that underlying patient, the more chances that this patient is going to get readmitted or die post-discharge. We are also very aware of the opioid crisis in West Virginia. We generally think of opioid crisis as a community crisis, which is killing a lot of people in there. We don't think of it as a hospital crisis, but there is a lot of opioid use within our hospital, and which we were cognizant of that time. We also knew that the potential combination of opioid with sleep apnea is very fatal from previous data which we had. So this is the first study looking at unrecognized sleep disorder breathing admitted to the hospital who were inadvertently given narcotics, whether for pain or other reasons. We found that this combination was the #1 reason for escalation of care in the hospital. And we defined escalation of care as going from a general ward to an ICU within that night. This chart and data may not be alien to you guys at all, because you faced with this all the time in the hospital. You come in the morning and the patient was transferred to the ICU because the patient was developing hypercapnia and somnolence all overnight. So hypercapnic respiratory failure, the combination of obstructive sleep apnea and narcotic, is a huge problem that we found out in a hospitalized setting. So another very good reason to pursue this going on forward. Okay, so I'm not able to move that. All right, here we go. Another problem is that patients with obstructive sleep apnea, from research from Mayo in the past, has shown that these people can suddenly die during the night. So we theorize that if they can die at home suddenly from OSA during the night, that same risk must be existing in a hospital. Of course, these studies for deaths and mortalities are more difficult, so we used a surrogate marker called the rapid response events. Of course, if a rapid response event is called in, there's something bad going on, and we selected events which were cardiovascular or cardiopulmonary in nature. And we found that the patients who were at high risk for OSA detected in a hospitalized setting had double and significantly higher risk of having a rapid response event during the night. And keep this thought in mind for a second, because there's a follow-up for this slide later on. So it's hammer time. So this and many other data from across the country convinced us that this is a major issue in a hospitalized setting. The issue was, can we do something about it? What is the answer for that? So this is one of the largest and initial studies that we conducted in Jefferson. And we took congestive heart failure. That's because that's the #1 cause of admissions to the hospital in the United States. And we looked at patients who had congestive heart failure, screened them for sleep disorder breathing, and instead of waiting, started them on treatment. And we followed them for a 6-month period of time. And what we found was that if these patients were compliant and were treated appropriately, starting from the hospital itself, they had significant reduction in not only hospital readmission, but also emergency room visits. We took this model and applied to the second most important readmission or admission in the United States, COPD. We did the same thing, intervened while these patients were in the hospital, started treatment for them and followed them for 6 months, and again noticed significant drop in readmission to the hospital as well as to emergency room visits. This is the first randomized controlled trial we do. As you all know, pulmonary hypertension is a fatal condition. And what we were interested was that it's not even fatal just as a group 1 pulmonary hypertension, it's fatal across the board, even the group 2. So we took patients with congestive heart failure who had demonstrated significantly elevated pulmonary pressures. What we decided to do was use CPAP machine within the context of a hospital and then treat these patients for 48 hours and see what happens. All of these patients are admitted within the constraints of a dedicated heart failure unit. And we did not interfere with the treatment. The cardiologist and the heart failure specialists treated these patients according to their standard of care. All we did was we randomized these patients who had underlying sleep disorder breathing to either get non-invasive ventilation for 48 hours continuously or not. And after randomization, we found that the treatment arm had a reduction of 15 millimeter mercury of pulmonary pressures as compared to only 5 millimeter from the other arm. So this is the first insight we received that we have a tool now to both acutely and chronically treat pulmonary hypertension from all causes with positive airway pressure therapy. We talked a little bit about rapid response events. So the question posed to us was, yes, that's very interesting that these patients are having a bad event during the night, but what can we do about it? So since we were already screening these patients, we decided to put these patients on treatment while they were in the hospital for non-invasive ventilation. And then we followed them for until their discharge. And we found that there was significant reduction in the group which was successfully treated within the hospital and had much lower rapid response events as compared to the treatment who did not accept CPAP therapy at night or failed that. Now, HOSMED database is one of the largest hospital sleep studies in the world that we know of. In this, we followed 5,000 patients who were screened in the hospital for an average of 2 to 3 years. And the first time we showed that it reduced mortality. So patients who were compliant with their PAP therapy showed better survival than compared to patients who did not accept treatment or failed treatment because they were non-compliant after 2 to 3 years period of time. So I think enough evidence over a decade had collected that Chest Journal asked us to share our model. And we published this about 3 months ago online. And we think that this has another potential of being a disruptive innovation. This paper is will be published online, is already published online, but we're in print next week. So if you need more data on the details of this paper, I'll be happy to provide it. Now, this time, American Academy of Sleep Medicine wasn't caught napping and decided to institute an inpatient sleep disorder breathing task force to come up with the guidelines. and I'm honored to be part of this task force. But I don't think that we believe that this alone will make a huge dent when you have 1 billion people undiagnosed with this disorder. We got to do something better than even this. So what is the next disruptive innovation that we can do? Well, there has been data come in recently that what if we could train healthcare providers, rural providers, in identifying sleep disorder breathing, treating sleep disorder breathing, and managing it? How would that change it? Well, again, the knee-jerk response would be maybe it would be a lot of wasted resources, we won't get the same outcome, so on and so forth. But I tell you that even in the state of West Virginia, there are no more than a dozen sleep doctors. So there's no way this high prevalence of disease can be handled just by a few sleep experts and a few sleep labs. So this has to be the next area of focus. In fact, research in Australia conducted a randomized controlled trial where they compared sleep experts with rural primary care doctors who have been trained for detecting sleep disorder, and then tracked them for 6 months. The outcome being Epworth Sleepiness Score, which is a very validated score of sleepiness in our world. And they found out at the end of 6 months that the reduction in Epworth Sleepiness Score, which basically is a marker for pathological sleepiness, was pretty much the same in both the groups. Both the groups did similarly as far as the outcome from Epworth Sleepiness Score is concerned. And this was quite heartening. In fact, a recent study, which was just hot off the press, people were able to train clinical nurses in obstructive sleep apnea. So I'm talking a very narrow constraint of obstructive sleep apnea. And in that randomized controlled trial, the outcome was found to be non-inferior to sleep specialists. So I think we have data coming up. There are more studies and more randomized controlled trials done. And this study is basically a meta-analysis of all this study. On the left side, you can see this dot analysis where the green is the primary care and the orange is the specialty or the sleep specialty care. And you can see there's not much difference across the board in the spectrum of OSA disease. What was very interesting in this meta-analysis was that without compromising the quality of care, without having any change in the Epworth Sleepiness Score, the care provided by primary care was less expensive than care provided by specialists. So we're not compromising on quality of care. We're not compromising on the outcome, and yet it could be a less expensive care. So I think this is another disruptive innovation that is going to be coming very soon. We have already started taking action in this regard. And as you all know, that we have the highest concentration of federally qualified health centers because of the rural nature of our state. And Dr. Stansbury from our section has taken the lead and forming a PI Academy, which is designed to treat or designed to train the physicians manning the federally qualified health centers to detect obstructive sleep apnea and manage them. So we are trying to be ahead of the curve here in West Virginia. Now, we also recognize that while OSA may be one of the commonest disorders causing healthcare disparities, there's a broader socioeconomic factors which impact sleep health, and then sleep health impacting our general health. We use this theoretical concept to define these factors, which can range from individual factors like I don't know what good sleep hygiene is, I don't know how to sleep well, and to more family-related effects like crowding, family stresses, things like that. And then the whole broader constraint of a sociocultural geographical strain, inner city patients, patients living in rural with poor access to healthcare. All of them have a role to play in sleep health. And this theory we published in CHEST to complement the treatment of OSA because we think this goes hand in hand. So taking this forward practically, we've thought that community engagement is the next level of disruptive engagement. So how do we practically do this? How do we do community engagement? Well, we embarked on a collaborative project with RNI and Healthy Harrison Foundation, which is a nonprofit foundation which is involved in preventative medicine. And what we theorized was that if we could train people to sleep well, maybe that'll translate to better sleep health, and maybe that will translate to better burden of disease down the road. So moving the pendulum from treatment to prevention. So we took a particular county, and it's called Harrison County, and we had taken over 100 patients from Harrison County. And what we are basically doing them is we are training them how to sleep well. So training the brain, and this is designed by a video, a 15 minutes video called the sleep hygiene video. And these patients can access it on the computer anywhere, anytime, and get trained on how to sleep well. So how do we look that is this working or not working? Well, one way is we are using technology to advantage. So we have used sleep tracking smart rings called the Oura Rings, and all of these patients have been provided with Oura Rings. And what this Oura Ring does is provides real-time data to us in terms of total sleep time, daytime alertness, heart rate variability, which is tied to all kinds of cardiovascular implications and diseases, and even psychomotor vigilance testing, which is a testing for your daytime alertness. And we're looking whether this community intervention, bypassing all the other things, is going to go to a sleep doctor, then you got to go to a cognitive behavior therapist, and so on and so forth, then going to the roots of it, can that be a disruptive innovation and help sleep health? Moving on to disruptive technology. So you're going to be wondering why I'm showing this slide. Why am I selling Radon on a grand round? Well, I'm trying to use this as an example. So most of us in West Virginia are very well aware of the radon problem that we have. Each one of us, either when selling or buying a house or some other reason, has conducted a radon test. And typically what happens when you do a radon test is you call a contractor, and the contractor says, well, my guy's going to come in and put a small gadget in your basement on your house. And then you have to open your house to him. Sometimes you come early because the time doesn't match. He keeps it, and then he wants to pick it up after 3 to 4 days. He picks it up, and then he analyzes it. After a week, he sends you the report. And by the end of the whole thing, it costs you about $400 to $500. Well, a few years ago, when our neighbors had a problem, I thought, why not we just proactively look at it? But I didn't want to have spend so much money. So I looked it up, and online, there's a radon gas kit for $14.99. You order it, comes to your home, you put it in your basement, send it, and you know within a day for $15 whether it's a problem or not. So why is this analogy important for sleep medicine? Well, here's what it is. Think of this construct as home sleep medicine being that contractor service. So you got a problem, your wife says you snore, you don't know whether it's sleep apnea, you go to a doctor, he said maybe, maybe not. Well, we'll do a home sleep study, then it goes to your insurance company, they have to authorize it, somebody then has to mail that thing to you, you wear it for a day, send it back, and then it takes several weeks for somebody to interpret that, you call it, so and blah. what if there was a kit that you can order online and say, you know what, let me first just check, how much water am I in? Is that even an issue with me? Should I even see a doctor? Things like that. So we have something like high resolution pulse ox in the hospital. Again, this is a very complex deal. There's a lot of complex signals. It has to be interpreted. It's not widely available in the community. So this led to what we call as the sleep apnea artificial intelligence projects. And we started thinking, what if we took this technology of high resolution pulse ox and then did supervised machine learning, where the machine learned itself the signals which it needs to pick. And then we applied other principles of artificial intelligence, especially topological data analysis, which basically look at different dimensions of the disease to create a novel phenotype, which may be better identified with these techniques. Utilizing the supervised machine learning techniques over multiple cases, we realized that we were able to detect signals which are not even currently used by HRPO, to even better and more precisely be able to screen for sleep apnea. And our preciseness increased from 86% to almost 96% with these signals. So then we used a software to take all of these signals and then process that into an interpretable report. And then we used another software to take this interpretable report to make it user-friendly in form of a color dial, which a patient can see on their cell phone, for example. And then we put all of this unit together and we tested a prototype. So in essence, very similar to a Radan test. You order this kit, you use it at night. In the morning on your cell phone, you'll have a dial with green, yellow, and red. The green says you have no sleep apnea, you may be snoring, but you ain't going to choke to death at night. Yellow means you have a mild problem, 5 to 15. Remember, we talked about earlier in the grand rounds that mild to moderate rarely causes cardiovascular implication. So you could make a decision, go to a doctor, or you could do some lifestyle changes, exercise, weight loss, and then redo the test in a couple of months period of time. Or red, which is moderate to severe disease, where you absolutely need to take action in terms of that. So we thought this may not be a bad idea. And we took it to the WVU Office of Technology Transfer, or OTT as they call it. And they said, yeah, that looks like a good idea. And they sent it for evaluation to an outside firm in New York. And the outside firm in New York said they really liked the idea. And lo and behold, they had asked us to apply for a patent. So in October of 2021, we applied for a patent for this prototype, and we are continuing to develop this prototype. And we feel that this is truly going to be very effective in the community, just like high resolution pulse ox has been very effective in the hospital-based medicine. And I think it's going to make a true dent, not in terms of only screening for disease, but imagine a world where you can do mass scale research on the community based on this very cost-effective kit. Now, none of this would have been possible, and all of this is a pipe dream until you have a team which really believes in these ideas, far-fetched ideas, is got the passion and the hard work to carry this work around. There are too many people in the last decade to list in this slide, but our current team, which has done a phenomenal job in the last 3 years developing these programs, I want to acknowledge them. From the pulmonary critical care and sleep medicine, Dr. Stansbury, Dr. Chris Pham, Cassandra Algers. Many of our fellows have been very deeply invested in this technology and this new science. a research assistant, Erica McCoya. And respiratory department, their never die spirit, despite heavy odds during the COVID, they did a phenomenal job and take this science to the next level. And last but not the least, our sleep center led by Greg, who helped us connect the dots, because anything we do in the hospitalized setting has to be connected in the outside world to make sure these patients don't fall through the cracks. In the end, I also want to thank you all, because despite COVID, despite a lot of stress around us in the last 1.5 to 2 years, you guys have allowed us to see and treat your patients. In the last 1.5 years itself, we have seen 1,232 and counting new consults. This doesn't count the follow-ups on the care we do on the floor. And the biggest contributors to that have been internal medicine, the hospitalist service, and our cardiology friends. So the question I pose to you is, are we going to embrace these disruptive innovations or risk becoming obsolete? And I think the choice is very stark in front of us. And the last, I'll leave you with this thought process and my own personal dream that one day airlines will provide these perks, that in the event of a severe snoring, a CPAP mask will drop from the compartment above. So I thank you all for listening today, and I'm happy to take any questions.
It looks like we have one from the chat. From an inpatient standpoint, how can we help patients with undiagnosed sleep apnea who are admitted with respiratory diagnoses? And how can we help identify it early so maybe it can help reduce length of stay?
Excellent question. As we said, that in an inpatient point of view, we have come up with this two-tier model where we use a very, very easy to use stop questionnaire, which has 4 questions. Do you snore? Are you having observed apneas by your family members? Do you have blood pressure? And are you sleeping? And 2 out of these 4 screens you positive. Once you have that high risk, then all you got to do is have an order for a high resolution pulse ox. We have a whole team of wonderful people with a sleep who will determine whether this patient is better off with a high resolution pulse ox or a home sleep study conducted by our own staff. And once they are identified, then depending, as I said earlier in the theme of the grand rounds, is that we know from our science and knowledge that mild sleep apnea can wait, may not need to be jumped right away because they have very little cardiovascular implication, but moderate to severe is a whole different story, both inpatient as well as outpatient. And then we start treatment right from the hospital over here. And we make arrangements that as soon as the patient is discharged, this patient is going to get either a home sleep study for confirmation or get to the sleep lab. In certain instances where we feel that the patient health is really, really compromised, we have actually sent patients home from the hospital on loners, or even prescribe these patients home ventilators, especially complex patients, hypercapnic respiratory failures, neuromuscular disorders, so on and so forth. So there are many, many ways that you can help these patients who are admitted to your service in a hospitalized situation. So I'm reading here another question. I'm so sorry, it's kind of a little bit small. Do you have preliminary results from the community partnership on Harrison? Yeah, Dr. Savari, this is a good question. We are right now in the recruitment phase. I'll be happy to tell you that as of yesterday, we have 77 patients already recruited in a trial. Our number to reach statistically alpha power, which we have calculated based on the community study, is about 120. So we are hoping that in the next few months, we should start having some preliminary results. Next one. Can you shed some light, particularly of the nasal breathing exercises, Snoring USA? In my practice, I find using nasal afferent challenge test often reveals that it's impaired nasal breathing is a causation of snoring. Very, very good point. Remember, right from the tip of the nose to all the way to your airways, there are potential areas where your airways can collapse. Having nasal congestion, having deviated nasal septum, having sinus problems, all of them contribute to not only snoring, but actually aggravating sleep apnea. So while afferent alone may not treat sleep apnea, but it often helps in patient getting better fit with the CPAP machine, able to tolerate CPAP machine better. And in some milder cases, as you just alluded, with snoring and maybe sleep apnea, and if they have severe congestion, nasal decongestants can help relieving those symptoms. I am not able to read the other one. There is another one from Sandra Cotton. Were there technology challenges with the rural community using the rings to obtain data? Yes, there's an excellent question. So we could do this study and we can just take patients' word for it, but we didn't want to do it. If this has to be a disruptive technology, we have to have good proof that this thing really works, and hence objective data is very important. And we can do that because technology is fairly advanced. We talked about significant disruptive technology which are coming up in the coming days and weeks. Now, coming back to the ring, yes, it's very easy to get data from the ring as long as you don't let it die. So there's a battery, and the battery lasts for 7 days, and we keep reminding these folks over in the rural community by either calling them or emailing them that don't forget to charge that ring. As long as the ring is charged, we can remotely collect this data on a platform. And lack of high-speed internet may hinder it, but our experience so far, at least from the Harrison County, and I too admit that is not really the boonies in the Harrison County, and it still has good internet connection. In the last 50 to 70 patients that we have had no problems collecting data. In fact, patients have been, I wouldn't call them patients, but subjects have been very, very enthusiastic. And they actually sometimes even call us and say, are you collecting my data? Is everything working out? So yes, it's not, at least for now, posing any challenge for us. And thank you for that question. I guess these are all the ones I can see on the chat forum. And I apologize if I'm missing a few. So are there any disruptive technologies? Dr. Savari is asking the intervention we have to treat. I think that field is also growing. I can tell you for sure what will stick and what won't stick, but we already have a very promising combination of two medication which has been tested in the lab, which can provide improved strength to our dilator muscles in the airways and prevent them from collapsing. So we don't know, we may even be looking at a pill form as a treatment for OSA in the next couple of years. There's some really cool, very low intervention surgical procedures which are coming up. One of them is called the Hyard suspension. And it's an outpatient procedure which lifts up your Hyard and strengthens the airways and prevents them from collapsing. So yes, there's a lot of work being done even in the intervention part of the sleep apnea. Thank you for the question. And I'm happy to take any further questions on email. You can approach me, in any way, email, cell phone. I'll be happy to answer. And again, thank you very much for your attention. And I know you all have clinical duties. to go back to. So I'll let you go. Thank you so much.